Hi, everybody, and welcome to the Family Matters interview series. Thank you for choosing to join the presentation, and we are so happy to have you here with us tonight. Just a few reminders that all lines will be muted throughout tonight's presentation. So if you have any questions, you can enter them into the chat box, and a member of the BCAT team will respond to you via email within 2 to 3 business days. We are pleased to have Bobbi Duffy joining us tonight to discuss how do I know when psychiatric care is needed for older adults with cognitive impairments and/or dementia. Bobbi is the Chief Clinical Officer and Director of Psychiatric Services for CounterPoint Health Services. She is also a member of the company's leadership team. She has been both board certified as a family psychiatric nurse practitioner and psychotherapist since 2007. She has over 25 years of experience in delivering, overseeing, and development of geriatric specialty programs. She also serves as a faculty member for Mansbach Health Tools, which supports the BCAT approach. Bobbi is an expert in both geriatric psychiatry and dementia, and she has presented on these topics in over 50 cities. Joining Bobbi is Lynn Young, the Vice President of Operations at Mansbach Health Tools. Lynn and Bobbi, I am going to turn it over to you.
Hi, everybody. Welcome to today's Family Matters call. We're really excited to be joined today by Bobbi Duffy, a psychiatric nurse practitioner, board certified in psychiatry, and the Chief Clinical Officer for CounterPoint Health Services and the Director of Psychiatry. Welcome, Bobbi.
Hi, Lynn. Thanks for having me.
Yeah, we're so excited you could join us and our families today. We really appreciate your time. Just to let our audience know a little bit more about you and your background and your role at CounterPoint, can you tell us a little bit about yourself?
Sure. I've been practicing as a psychiatric nurse practitioner for a little over 15 years. Prior to that, I was a registered nurse, I think for about 12 years. I'm aging myself there. My career as a nurse practitioner, as a psychiatric nurse practitioner, has been almost solely focused on the geriatric or the medically frail population. I'm pretty lucky that I've been with the same crew for so long. I actually got to do some of my clinical rotations with a former group that we've evolved out of back in the early 2000s. So not only have I had the privilege of being involved in the growth, but I've grown a lot working with this team.
Awesome. Sounds like you have a lot of experience, been doing this a really long time.
I have, but you know, Lynn, you learn something new every day. And I talk about it all the time. I learn something from every member of our team, not only our clinicians or operational staff. It's a great team, and we're all growing together.
Great. I know you've been with different variations of the same organization right now, working for CounterPoint Health Services. If any of our audience members aren't as familiar with CounterPoint, can you tell us a little bit about what does CounterPoint do? What are some of the services you all provide?
Sure. So CounterPoint is a behavioral health practice. We serve Maryland and Virginia on site. We do a little bit of remote work in those areas as well, doing some virtual visits. The majority of our work is actually boots on the ground in long-term care, skilled nursing, rehab centers, assisted livings, independent livings. We do some special programs with some centers of aging. We do a lot of stuff. We work closely with some primary carers to bring some telepsychiatry and telepsychology into patients' homes that wouldn't necessarily be able to get services otherwise. Our team, the psychiatry team, partners closely with our behavioral health team to really, our goal is to improve the mental health of all of our patients, even those patients that are seen as beyond improvement. The patients suffering with various cognitive ailments, especially dementias. And we're just looking for little ways, and those little ways are sometimes big deals to improve their quality of life, to decrease suffering.
Absolutely. Well, I know that the psychiatry role and that sort of focus area is really a broad, covers a lot of ground, right? There's lots that you all can do to really help support older adults and their families. I know one area that families are really interested in hearing more about and often ask questions around is medications. Can you tell us a little bit about how you all decide as mental health professionals what medication might work best for someone? How do you sort of go about determining if they are a candidate for medications?
So it's a pretty complex question, and it really starts with a lot of foundational work. And when I say a lot of foundational work, doesn't mean it's a long time till we make a decision and implement a treatment, but there's a lot we need to know. So to assess a patient from the psychiatric standpoint, for a patient, it may look, especially in the inpatient settings, it may look a lot like any other medical appointment with a doctor, an end date or an end date. It may look just like that. We come in, we speak with a patient, we may do some actual hands-on physical assessments, looking at neurodeficits. We ask a lot of questions. We ask a lot of historical questions. When did this start? How severe is it? Oftentimes, most of the time, our patients are not able to give us the full history, or they attempt to, but they're not able to give us necessarily reliable history. So it's critical to involve their loved ones to give us some background. It's also critical, if we're talking about an inpatient setting, to involve the staff there, the nursing staff, the physical therapist, the occupational therapist. If our psychiatry team is lucky enough to be number 2 in from CounterPoint, then of course we're relying on our behavioral health partners from CounterPoint. So we're gathering all this data from people. We're also gathering data from the medical record. We're looking at their history, maybe recent surgeries. We're reviewing labs, just looking for little clues. We're looking for the clues of why is this not a psychiatric problem? That really is how we start. We don't go in wanting to find the psychiatric problem. We want to find out why it's not. And by doing that, we'll identify little things sometimes that I refer to as the low-hanging fruit. And treating those often does not resolve the whole problem, but it puts that patient closer to the starting line. So we're assessing all the things. Oftentimes we won't have all the information we need. It may be a new admission to an assisted living that recently hasn't had lab work. We'll order that lab work. We may make a decision to make a treatment, to prescribe something before we have the lab work, depending on the choices we're making. And that might vary once we get the lab work back. But so we're gathering lots and lots and lots of data. It's not just we walk in, they're depressed, here's some Celexa, have a nice day. We're really looking at it. We're also considering side effects. So, and many times we're considering side effects to the point of how can they help us? So if I have a patient with a poor appetite, well, there's a medication or multiple medications out there that increase appetite. That's a really bad thing if you're, in your 30s or any age and overweight and already struggling with eating too much or gaining weight. But if you're not eating, can't encourage you, increase your appetite to good things. So can I help you with your depression, your anxiety, and maybe improve your appetite? So we make decisions on that. We're looking at side effect profiles and how do we use those in our favor? Obviously, we want to avoid any negative side effects, but sometimes they're really useful in treatment. So I don't know if that answered your question.
Yeah, I think that's a really good overview for people to be thinking about. There's a lot that goes into sort of the assessment, gathering the information, learning more about the individual needs of each individual resident, and kind of taking that information and layering it against what medications might work and how do they work and what's really right for each individual person. So
one comment, if you don't mind, Lynn, is that there's often not a good answer. Often we're choosing the best medication of medications that aren't so great. And that's just the reality in our older population because they have so many medical comorbidities. Because oftentimes there are 9, 10, 12 other medications that we're very concerned about the interactions with. So we often make the best choice of not great choices. And we make that choice anyway because we want to improve this patient's quality of life. When I say quality of life, I don't think they're going back out to work. I don't think they're going to do their own grocery shopping, but can they sit and smile and enjoy a visit, even if they don't remember or necessarily recognize, have moments of joy or less moments of distress. So those are part of the things that we're always thinking about. It's very difficult in the older population to really find something that you would say is safe. Everything has its risks, and that's true in the younger population too. Sometimes I'll joke with the staff and I'll say, okay, give me your grandmother's hairbrush, a rubber band, and a hard-boiled egg, and we'll fix it. I mean, it really, we just have to be creative. Everyone is so different, and you got to listen, even to those that aren't talking, because there's so much for them to tell you just by the way they make eye contact. There's so much information there.
So once you all have done your assessment, met with the patient, the family members, the teams in the community, and you've provided that medication, how does your team monitor or adjust those medications to make sure that the dosage is correct or that they're working, in the way that you intended them to do and they're meeting their needs?
Yeah, that's a great question, and a really, really important question. We've signed on for the care of this patient. And along with that, we've signed on for the responsibility of the safety of this patient. So we're going to reassess a patient. We're going to meet with them again, either in person or virtually, and that varies on many, many circumstances, what's best for the patient. And we may meet there's no formula. So you may be working with a patient that really needs to be seen again that week, or you may work with a patient that, okay, they're okay for 2 to 3 weeks, but we do follow closely. Our population is really at risk for having side effects, is really at risk for falls. So we want to monitor closely, and most of the time we're in an inpatient setting with an excellent supportive staff, the nurses and the therapists, but sometimes we'll pick up on things they don't pick up on. So we really try to follow as closely as possible to get started. You kind of start seeing them, I'll see you once a week, and it starts to spread out as you feel better and better about the treatment. Many times we'll start a medication at a dose that we know is not going to do the job, but all brains, but particularly elderly brains, do better when we slowly introduce the psychotropics into the brain and make slower adjustments. Big abrupt adjustments feel to the brain like big abrupt adjustments. That's when people fall and are unsafe. So we want to steadily increase the medication. Many times I've heard somebody has been, they're allergic to that. They had a bad reaction to that. And as seriously as I take that, I also want to know more about how that medication has been introduced. If you introduce somebody at a bigger dose, they're sometimes more likely to fail, even though it's the right medication. Sometimes knowing that we're not going to get to the end result for an extra 4 weeks, and slowly titrating it is better than just wiping it off the table by overdosing someone initially. Not overdosing to the point of causing an injury, but giving them more than their body is ready to adjust to. Another really significant factor to remember is that we're not only going back to make sure that the medication is working, okay? We're going back quickly. So antidepressants, classically, you don't see your desired effect, if you're lucky, with the first dose and prescription you write for 4 to 6 weeks. But I prescribe that to a depressed patient. And that depressed patient who's not going to get relief for 4 to 6 weeks, maybe a little bit before, is still depressed. And I've taken on the role of making sure that's not getting worse. I need to know that they're not getting nauseous from it and not tolerating it. There's not something else we need to do. So we do follow closely because we're trying to improve quality of life, not worsen it. And if we just give you a medicine and walk away and go, good luck with that, it doesn't usually work out as good as it could.
Absolutely. And I know families are really tuned into these changes in their loved one. I'm sure with the medications, they're paying really close attention and looking to see changes, improvements, lessening of symptoms, just like you described. Um, what should families be looking for? What symptoms should they be looking for in those older adults when they're expecting to see these changes in mood? Or what should the staff maybe who are supporting these folks be looking for and be able to report back if they're seeing these improvements or changes?
Know your loved one, and you already do. So know your loved one. And one of the things at Counterpoint that we take super seriously is our engagement with the family members of our patients that aren't able to make their own decisions. As long as we have the legal authority or they have the legal authority to talk with us, we want to engage them as much as possible. And even times when they may not be the medical power of attorney, but the patient's a little bit, I'm not so sure, we'll ask the patient, did you want us to talk about this with someone in your family? Do we have permission? And they usually do want that additional support. So from the beginning, we're trying to set families up to understand this is going to take some time, keep an eye out for this. They're always welcome to call us. The cool thing about Counterpoint is all our clinicians have a Counterpoint phone. So that's like a desktop, the old phone on your desk, that's our line. You're welcome to reach out to us, to your clinician directly. If it's an emergency situation, we obviously want you to go through the office because that clinician could be off or unavailable for some different reason. But so to say, just know your loved one. Don't expect miracles overnight. We're not magic workers, and also be prepared sometimes for some ups and downs as things get started. We like to hear more than less. So if you're seeing something you're like, I'm not sure that's important, well, check it out with us, or at least check it out with the nursing staff, because many of our facilities have had the same clinician, or at least the Counterpoint team, for years. And they've been very well educated by us. They go, oh, sometimes that happens, but we're always available for that. Just from the beginning, one of the most important things that the clinicians, that includes me, need to remember is that we are not the expert on that patient. Families have known that person for 30, 40, 50, 60 years. They're the expert on that patient. Now, we are the experts on psychiatry. But if either one of us thinks we can do it alone without partnering with the other, we're not going to be as successful as we possibly could. So that partnership is just critical. So families look for changes. We try to update families ahead of time on what to expect, but everyone's a little bit different. One of the things that I think that all of us hear is they just want to make my mom a zombie, or they just want my aunt to be quiet for the nursing staff. And if I could dispel one myth, that is not true. If I prescribe something to a patient and they become sedated, I've overshot my mark. Guess what? It's going to happen. Everybody's different. There's no magic number. The lowest possible dose could be a little bit heavy for a new patient to us. But we try not to do that, but sometimes it happens. We need to hear about those things. We do need to hear about those things so that we can adjust back, pull back. Even that lowest possible dose could go to every other day in some cases. And some of those initial reactions. So if you have somebody that's been anxious and off the chart, and we're starting them on a very, very low dose of something for that anxiety, and they take a nap for a day and a half, but they haven't been sleeping, they might just be catching up. So it's all variable, but we like to hear about anything. It's not bothersome to us, and sometimes it actually saves lives.
That makes sense. So, Bobbi, tell me this. You did a really great job giving us some background on what that team looks like in a nursing home or in a senior living community where you have nursing staff and physicians and maybe other healthcare professionals that are around that patient that can share information with your team, kind of keep you informed. Tell me a little bit about how does someone who's at home, in their own home or in their own apartment, get connected to a behavioral health provider if they need that kind of support without all of the extra, levels and layers of healthcare practitioners around them to help guide them?
We have a great question. We have a community resource center that can be reached at CounterPoint. I'm going to move you a little bit. Just counterpointhealthservices.com is a great, you can email us, you can reach out to our main number, which I'm going to adjust my screen again, 410-929-7225, to reach out to us. Now, I will say that there are many patients in the community that could use our services. Not every single one of them is appropriate for our services. So if you imagine if someone's still living at home that's very confused about medications and at risk, well, not always is it the best thing to do to add more medications to the mix. If they aren't familiar with technology and don't have somebody right there to help them, well, they may not benefit from psychotherapy or neurocognitive therapy virtually. It might be just something where we do some testing, neurocognitive testing, bring them into our office, and then help families to guide to placement if they're ready for that. If a patient is appropriate for services in the home, it's going to be a pretty extensive paperwork process in the beginning, because we do need to know from your primary care what medications you're on, what diagnoses you have. That's all about safety, number one, and number two, it's all about getting a good result as soon as we can, relief from your symptoms. So they can expect to either meet with a psychiatric nurse practitioner or a psychiatrist, as well as one of our social workers or psychologists remotely. And then we partner behind the scenes to talk about things. We're able to electronically prescribe medications to a pharmacy if it's appropriate. Each patient is really case by case, though. And we love that we're able to bring these services into people's homes. But we really do need partnership from family and loved ones to make that happen efficiently. One of the main reasons that we're called in is because the person has had some cognitive changes. And so we need family support. And we're always here to talk more and brainstorm. Meds are awesome and they do serve a place. But one of the things at CounterPoint is we want to, especially if you're seeing us through outpatient, for you to see both sides of the house. I mean, the gold standard is really psychotherapy, supportive therapy, behavioral interventions with meds if needed, but not meds alone. You really need that team approach.
Now, would that same approach work for somebody with, let's say, a dementia diagnosis? Are the goals of assessment and treatment different for those types of folks? I know there's a lot of families that join these calls that have a family member or a loved one with a dementia diagnosis who are probably looking for some, levels of support. Can you tell us a little bit about how that might differ for that particular type of population?
Absolutely. So for a patient that has a more advanced dementia, I mean, there are patients that have dementia that are able to join and work with us pretty independently with just a little bit of support on the side. For those with a more advanced dementia, we're usually called on the scene because there's some challenging behaviors of sorts. So that's when we work closely with families, our behavioral health team, and our psychiatry team work closely with really trying to understand what's happening, what's triggering. And that might be several phone calls or conversations or virtual visits. So we really get a grasp of that. Medications will serve a place for that. A lot of times we'll find that the families just need some support making a decision on whether or not this person is still appropriate to be home alone. And a lot of times the families need support to know that it's okay to ask for more help. I so often work with families that really struggle with the guilt of having made a decision to either bring in additional services besides themselves into the home, or to place the loved one into an assisted living. It's just this guilt. I promised mom I would never do this. And sometimes is the best thing, because suddenly that daughter who loves mom, who's been making sure she has food and kind of distressed with mom for not for little things, just for not shutting the refrigerator, for those for getting meds again, she can't be a daughter anymore. She has to be a caregiver. And we can hire a caregiver. We can find somebody to prepare meals and clean a house. In most cases, can't hire a daughter. And so it's really can be so much better for the families when they get clarity on where the patient is in their disease process and where their functional strengths and weaknesses are, and if they're going to be successful in the home, and how much longer that family member can continue to just be a caregiver and not be that loved one that they really need.
Oh, I love that. Those are really great words of wisdom. I think a lot of times people take on the responsibility of caregiving, and it's really a lot on them and their family members and their, routines in their lives. So it's okay to reach out for help, I think, is a great message. And it sounds like your team is well equipped to kind of provide that guidance on that journey and help them find what they need.
We hope to be.
Really
we hope
great.
to be.
Yeah, that's a really great point. I know we're almost out of time, but I did want to ask you this question because you brought up family members. And I know since the COVID-19 pandemic, I'm sure a lot of families have been isolated, been really trying to navigate on their own. I've heard from lots of family members, there are, frustrations, barriers, things that they're really struggling with to get the help that they need for their loved one. Are you seeing that in the folks that you work with? And then second part of that question, what suggestions do you have for family members?
So I absolutely do see that family members, and I see that actually in the caregivers and the inpatient settings, and I see it in some of our clinicians. I mean, it was an extremely traumatic period for everyone. It was traumatic for the family member doing a window visit with their loved one. And it was also traumatic for the caregivers, the paid caregivers on the other side, to see that patient not be able to hold hands with their loved ones. So the first thing I would say is realize that, and this is kind of cheesy words, but we're still all in this together. We've all really felt the impact of this and felt the pain of it in ways that aren't always imaginable to the other side. So having that empathy. It was a really scary time when you couldn't walk in and see your loved one. And so a lot of other forms of communication, email, text, calls to the staff in the facility, all they were doing was keeping people breathing, basically. So they were able to manage that. They didn't have guests. They weren't doing activities. People weren't dining in rooms. Now, as they're trying to get lives as back to normal as possible so that our aging patients can have the best quality of life possible, some of those forms of communication are a little bit more difficult to get an instant response on. So I ask families and loved ones not to blindly trust, but to trust, to go in and get those visits and meet with the staff and see their loved one in that environment and slowly breathe in that sense of, okay, we're here again, take a deep breath. Trauma is real, and we all felt it together. I will not minimize that in any way, but we're now moving on to the next phase of it, and it's okay to put some of that trust back in the staff if they're worthy of it. But don't feel like you still have to know every detail of your loved one every second of the day, because that takes away from your life. You still get to be a daughter, a sister, a brother, a spouse, and if you're able to enjoy your life and have moments just for you, you're going to be so much better for your struggling loved one.
Yeah, I'm sure that it's difficult now. We put so much time and effort into transitioning into a new normal. Now we all have to work to bring
another one.
Now to come back again the same way we just came and kind of refocus and, address things in a new way. So it really does take some time, I'm sure, to kind of pivot your thinking and embrace things for the way they used to be. And now move back to that, old way of life.
It really does. And we'll never be back there. And it's just that collectively, the passion has been from both sides of the window, has been are patients that were really struggling during the pandemic and their family members. So across the board, we all share the same goal. So communication is great. Share your thoughts, your feelings. I mean, really do. I'm not joking when I say share your feelings. We want to hear about those because we can often relieve some of that anxiety just by having a conversation about it. So I can go
Absolutely.
on and on. I love the work I do. I love the people I work with, and I love the patients I work with. So
Well, you've given us a lot of great information for our family members today. I know they'll take away some new ideas, different ways to access behavioral health services, considering medications, and just some of these stress relieving options for families, I think are all really great kind of takeaways for them. If somebody wanted to reach out to CounterPoint, do you all have a website that you can share as well?
we do. It's counterpointhealthservices.com. And that will just go to general, but it will get diverted to the right people. And
Great.
we also have a main phone number, 410-929-7225.
Great.
You're welcome to call. We have coverage 24 hours a day, 7 days a week. If you're going into a voicemail, you'll get a call back pretty quickly. Maybe not at 1 a.m. unless it's an emergency, but we should get back to you quickly.
Excellent. Well, thank you. Thank you for your time and all of your expertise today. We really appreciate you taking the time to join us. Have a great day.
Awesome. Thanks, Lynn. Take care.
Thanks. Thanks, everybody.
Bye-bye.
Thanks for joining. Bye-bye.
All right. Thank you so much, Lynn and Bobbi, for that awesome presentation. We would also like to take this opportunity to invite everybody to become a member of the Enrich Brain Health Program by signing up on our Enrich website, which is enrichvisits.com. And if you're interested in more information from the BCAT Research Center, you can follow us on Facebook, Instagram, Twitter, and LinkedIn. And here are those links on the screen. Again, if anybody has any questions, you can enter them into the chat box, and a member of the BCAT team will respond to you within the next 2 to 3 business days. Thanks, everybody, for joining this episode of the Family Matters series, and we hope to see you again for our next episode in June, entitled The 15 for Me Program, Reducing Caregiver Stress and Supporting Wellness. I'm going to leave the meeting open for a couple more minutes in case anybody has any questions. And otherwise, I hope everybody has a great night.